Okay, let's start. So welcome everyone to this Tuesday Lunch with Rita webinar. I am Martine Perjean. I am the president of IPOPI, the International Patient Organization for Primary Immune Deficiencies. And I am also the representative among the ERN-RITA representatives of the patients. So this is my great pleasure today to welcome you all to this webinar on a very interesting topic, which is chronic poliovirus excretion in PID, a global concern for polio eradication. I have also the pleasure to introduce you to Alexandre, who will take the floor. Alexandre.
Thank you, Martine, and welcome everyone. So I'm Alexandre Belot. I'm a pediatric rheumatologist in Lyon and the chair of these webinars of RITA. And we have not totally finished the program yet for this year, but it will be available very soon. Today, we are very pleased and honored to welcome Dr. Ondrej Mach, who's a speaker from the World Health Organization. And that's the first time we welcome someone from WHO, and it's a great researcher and talk that we will have about polio, which is a whole disease and not eradicated, and that can be an issue in primary immunodeficiencies. And as usual, you are very welcome to ask your question on the Q&A, and at the end of the discussion and the webinar, we will answer all the questions you have raised. So don't hesitate to make it on real time. And so now, Ondrej, the mic and the floor is yours. Thank you very much.
Thank you so much for the introduction, and it's really a great honor for me to be able to speak to this group. I am a medical doctor specializing in infectious diseases, and I work at the World Health Organization in Geneva in the polio department, where I'm responsible for clinical research into new vaccines and the eradication effort in general. So I hope you can see my screen. Can somebody confirm that that's the case? Because yes, I'm not sure I get it on the right.
Perfect, Ondrej.
All right, thank you so much. So we'll go for about 20 minutes through the presentation that we prepared for you, where I'll discuss why we believe that the children with primary immunodeficiencies are a concern for polio eradication, why the chronic poliovirus excretion is a problem, and then I hope to be able to discuss with you your thoughts, your opinions about what we are talking about. So first of all, what is the objective of today's webinar? We would like to raise awareness about among clinicians that work with children with primary immunodeficiencies regarding long-term poliovirus excretions with certain forms of PIDs, and why we think it's a risk to global poliovirus eradication effort. And also, we'd like to discuss and explain to you how you could participate in the effort to detect these children and treat their long-term poliovirus excretion, what it means and how this can be done. I'll introduce you to poliomyelitis. I'm sure you all know it, but probably very few of you have actually seen a polio case anymore. In Europe, this has been eradicated decades ago. I'll talk about where we still have polio briefly, and then about the risk to the eradication posed by the chronic excretors among PID patients. And the last part will be how you could help us reach that goal of poliovirus excretion by detecting and treating the chronic poliovirus excretors among your patients. So you probably all know that poliomyelitis is a viral infectious disease caused by enterovirus, poliovirus. The transmission is mostly oral-oral or fecal-oral. And most of the infections are completely inapparent. About 72% of those that are infected with poliovirus never are discovered, never are diagnosed. About a quarter of them have minor illness, which resembles flu, and less than 1% develop paralytic symptoms, which are lifelong. Once you have paralysis, there is no treatment. Infected healthy individuals, and this is important for the eradication effort, excrete poliovirus via pharyngeal or intestinal shedding for about 4 weeks, after which they are no longer infectious. However, Some individuals with primary immunodeficiencies may excrete indefinitely, and they become chronic carriers of the virus and can be a source of infections and seeders of new outbreaks in the post-eradication era. So this is where it is important for us to start discussing with clinicians in PIDs and societies of immunodeficiencies in different regions and different countries to raise awareness about this problem. We don't want to see pictures like these. And this, when I travel to India and Africa, you still see children and adults affected by polio around in different parts of the world. And of course, you all know how it looked like in the 50s and 60s in the US and in Europe, where outbreaks were occurring frequently, and many children ended up in what was called iron lungs. And in fact, interestingly enough, there still is at least one person that we know of who still lives in an iron lung for decades now, an old man now in Texas in America. In terms of epidemiology, this is how the world looked like in 1955, where pretty much the wild poliovirus was endemic throughout the world, and as I said, caused these periodic, very much feared outbreaks, which left many thousands of children paralyzed. In 1988, the WHO and the world collectively decided that poliovirus is a good candidate for eradication effort, and a goal of eradication by year 2000 was set, but we are in 2023, and as I will explain to you later on, there are still areas where endemic transmission continues. In 1999, you can see that some parts of Africa and Asia still had transmission of wild poliovirus, but Europe and developed countries no longer had any polio infections. And since 2021, there are only 2 endemic countries with wild poliovirus, which is Afghanistan and Pakistan, as you can see on this map, and we are still trying to eradicate the last areas of endemic transmission. Poliovirus eradication is the largest public health effort that has ever been attempted, and currently the goal is to eradicate poliovirus by the end of this year, which may or may not be realistic, and you can make your own opinion by the end of this presentation. We have 2 vaccines that are used to help us achieve the eradication. The original one was an inactivated polio vaccine developed by Salk in 1955, which is a killed virus administered by injection. The problem is that it has a low impact on mucosal immunity, which means it does not prevent infection. It prevents paralytic disease, which is great. But in terms of eradication effort, it doesn't serve the purpose of interrupting the transmission chains of the virus. The oral polio vaccine is a live weakened virus vaccine, the second one developed in 1961 by Sabin. And the problem of this vaccine is that it is a live vaccine, and therefore, in rare circumstances, it can mutate and start circulating on its own, causing outbreaks of what we call vaccine-derived poliovirus, or VDPVs. And these outbreaks today are more important than the residual endemic transmission of wild poliovirus. And I'll talk about it later. And this is where the immunodeficiency problematic comes into play. So what's the strategy? We have 3 main pillars of the eradication strategy: ensuring high coverage of routine immunization vaccines which children receive at young age. We have vaccination campaigns as a response to outbreaks where we vaccinate everybody irrespective of their vaccination status, typically less than 5-year-old children. And sensitive surveillance for polioviruses, so to understand where there still is transmission ongoing. And this surveillance has 3 different parts. The most important one is the surveillance for acute flaccid paralysis, or AFP, where we collect stool samples from paralyzed children and check for presence or absence of poliovirus. Then we have environmental sampling, where there is a network of wastewater collection sites around the world, which periodically, maybe once in 2 weeks or once every week in the more important spots, the water collections, wastewater collections are carried out, and the water is checked for presence or absence of poliovirus. And the third part is where you would come in, is the poliovirus surveillance among persons with certain immunodeficiencies. Typically, these would be non-paralyzed patients with PIDs of interest, and I'll go into it more in detail in the next several slides. But before we do so, I just want to remind you of what types of polioviruses there are. I mentioned the wild polioviruses, which were the ones that we originally thought were the only ones of importance in 1988 when this program of eradication started. And they have 3 serotypes. The serotype 2 and serotype 3 have already been certified as eradicated. And the only remaining serotype that circulates in Pakistan and Afghanistan is serotype 1. And of course, if you have circulation in one part of the world, nowhere is safe. As we saw with COVID, everything travels very fast, and exportations of the wild type 1 happens periodically to different parts of the world, which we can detect through our surveillance. But apart from these wild endemic polioviruses, I mentioned the problem of vaccine-derived polioviruses, which are mutated polioviruses from OPV vaccine, and most become what we call circulating vaccine-derived polioviruses, or CVD-PVs, and can start outbreaks such as indistinguishable from wild poliovirus. Their epidemiology, neurovirulence, and control measures are very similar to wild polioviruses. We cannot really distinguish without sequencing whether the disease was caused by wild or VDPV virus. And again, these may emerge in immunodeficient persons, and then we relate to them as IVDPVs, or vaccine-derived polioviruses from immunodeficient persons. This map shows you where we have detected cases of paralytic polio in the previous 12 months. The red dots here in Afghanistan and Pakistan are cases caused by wild poliovirus serotype 1 in the last endemic zone on the border between Afghanistan and Pakistan. And you can imagine that that area is very difficult to reach with vaccination campaigns, with vaccines, because it's a very insecure area where, you know, it's difficult to really do anything. But the good news is that the endemic zone is really confined to a fairly small geographic area. The bad news is that people do travel even from these areas, and you know, the air travel anywhere in the world is very fast. The orange dots and green dots, which are much more frequent than the red dots, are the paralytic cases caused by the vaccine-derived poliovirus. And you can see for the program, it is more difficult now to deal with the vaccine-derived poliovirus outbreaks than with the original endemic wild poliovirus. You can see many countries in Africa affected by either serotype 1, which are the orange dots, or by serotype 2 of the VDPV, of the vaccine-derived polioviruses. And these are more important outbreaks, and some of these are involving immunodeficient individuals as well. So let's talk a little bit about the chronic poliovirus excretion and the part that is relevant for this seminar. In rare circumstances, some individuals with certain types of primary immunodeficiencies, when exposed to poliovirus, and this could be either the wild or more commonly the poliovirus from OPV vaccine, develop chronic infection and excrete the virus installed indefinitely. That's why OPV, oral poliovirus vaccine, is contraindicated to be given to persons with PIDs. And in this situation, the poliovirus can mutate, acquire neurovirulence and transmissibility characteristics of wild poliovirus. And the PID individuals can be infected either from the vaccine itself by being vaccinated in error, or they can be exposed to the vaccine virus, for example, from their siblings, from their brothers, or from children they go to school with, or from others that they are in contact with. So it doesn't have to be the recipients of the vaccine themselves. Recognizing the risks of chronic IVD-PV excretion, we established that the surveillance is an integral part of the program, together, as I said, with the AFB environmental surveillance. So we have looked at what immunodeficiency disorders are linked with the chronic shedding, and I will talk about it a little bit more, but it needs to be those affecting B cell systems. So the T cell only, for example, HIV, are not linked to chronic excretion. So the B cell system needs to be affected. So these children are at risk. And they will constitute the only remaining reservoir of poliovirus after eradication is certified, and may become sources of poliovirus outbreaks and delay certification of poliovirus eradication. So what do we know about these viruses? We know that they can cause paralysis. They are neurodegenerative. We have seen children that we followed up on who developed IVD-PV infection without being paralyzed, but after some months, the virus mutated further and caused paralysis in the host. We are not sure about their transmissibility, but we believe that in absence of further evidence, we have to consider them transmissible. There were some instances of outbreaks starting from PID persons, from IVD-PV excretors, but the link is not completely conclusive. We have some indications from USA, from Spain, from Philippines, and from Israel, where PID children infected with poliovirus were linked to outbreaks that then started in these countries. We also know that the genetic signature, the sequencing of the virus is specific and provides useful information when we find isolates in environmental waters, even though we do not find the persons themselves. IVD-PV is a risk to poliovirus eradication and is not compatible with global poliovirus eradication. The risks are, as I mentioned, progression to paralysis in the individual himself or herself, but more importantly, for the eradication effort, it's a risk of community spread and seeding of outbreaks, which I have already described, perhaps happened in several countries. So we have two tasks. We have a task to detect the IVD-PV excretors, and this is why I'm talking to you, to see how WHO could work with societies such as yours, with PID clinicians and experts in helping us detect the IVD-PV excretors. And once they are detected, we have to offer them some sort of treatment. There is a whole program on development of antivirals and monoclonal antibodies to help stop the chronic excretion in these patients. There is one antiviral called pocapavir, which is a capsid inhibitor, which is available now for compassionate use. However, we have seen rapid development of resistance, which is a challenge, and that's why we are developing a combination antiviral to overcome the resistance problem. We've had a registry of IVD-PV excretors that looked back all the way back to 1962, and so we can see that it is a very rare event. It's a rare problem, but I think you all work with diseases that are very rare, so this is not new to you. So far in our registry, we have less than 200 reported cases of prolonged or chronic excretion of IVD-PVs. And you can see on the right side the countries where we have been able to detect these cases, and some are in Europe, but most of those we have detected were in North Africa and the Middle East, and this is because you know very well that the primary immunodeficiencies are more common in countries where consanguine marriages among relatives are more common. Therefore, the IVD-PV excretion is more common. The other reason is that we looked there more closely. We had special programs with Egypt, with Tunisia, and other countries that helped us detect these cases. We have seen that common variable immunodeficiencies, SCID, or other combined humoral deficiencies and antibody disorders are specific PIDs with known risk of long-term excretion, and I'll show you on the next few tables the percentage distribution of these disorders. So what were the outcomes of the long-term excretion out of the 200 children that we have in our database? We lost about a third to follow-up, about 40% died, and about 30% spontaneously stopped excreting the virus. And the antiviral that I mentioned before really wasn't used so much. So we are just starting with trying to use it on more and more excretors. So far, we are able to successfully treat only about 10 excretors with this bocapavir that I mentioned before. So far, we have about, I think, 11 known excretors that are currently shedding IVD-PIDs. They are all over the world. Perhaps the most interesting case is the last note there in the end of the slide. There was one person in Birmingham, I think he's with CVID, but being excreting a virus for more than 35 years, but he apparently stopped shedding because he got infected with COVID, treated with remdesivir. So we are actually looking at remdesivir as a possible agent for poliovirus as well. So far, we don't have any conclusive results from that, but you know, the excretion can last for decades. And so if we are talking about eradication of the poliovirus, this indeed is a problem for the World Health Organization and for the eradication program in general. So let's look at some of the demographic data from our registry. Most of these children that are excreting the polioviruses are young. We have about 3/4 or even more that are less than 5 years old. And these are the underlying immunodeficiency disorders that we have been able to see in the children that were in our registry. So you can see that the most important ones were SCID and CVID perhaps. And about 2/3 were paralyzed, but that might be because the AFP system surveillance, the acute flaccid paralysis surveillance system, was more successful in identifying these children than if they were not paralyzed. So what are we asking from you? And you can see here a picture of me and Dr. Jose Hagan, who was supposed to give this seminar with me, but was unavailable in the end. At the conference in Göteborg last year, where I think I met some of the organizers of this talk, and I'm very grateful for being able to give this talk to you here. We are asking you to be aware that chronic poliovirus excretion exists among your patients. It can be among patients who came into contact with live poliovirus vaccine. And OPV is no longer used in the majority of EU countries, of European countries. Only a handful of European countries still use OPV to immunize their children. But there are many children coming from OPV using countries and seeking care in Europe. We had recent cases like that in the UK, and one very recent in France. I think it was in Toulouse. There was a boy coming from Morocco for a treatment for his PID, and Morocco is an OPV using country, and an IVD-PV was detected in this child. So you know, patients coming seeking treatment in Europe from OPV using countries are perhaps a primary target, or it can be a citizen of Europe, but they travel to an OPV using country and picks up the virus somewhere there and comes back infected and becomes the excretor. So perhaps, you know, awareness is one thing, perhaps sensitization with any partnership or other non-EU PID institutions guiding us in a way where you think we might go to raise awareness about this issue among the societies of PIDs or clinicians in the different institutions would be very much appreciated. So what we are asking you is keep polio on your mind. There are guidelines that are online. Here's the link. I believe you will receive this presentation. You can check the link. There's the guidelines for implementing surveillance among patients with PID. And so when suspicion exists, for example, a PID patient comes to you from an OPV using country, consider looking at the guidelines. Perhaps colleagues will contact us. Let us know that you have such a patient. As I said, it's a very rare event, but it's an event that we cannot ignore. And if IPD-PID is detected, WHO will provide assistance with management of the child and with antiviral treatment as well, of course, under the guidance of the clinician who is taking care of that patient. So that's all I have regarding the presentation. And again, I thank you so much for giving me the chance to present here and for your attention.
Oh, thank you very much, Ondrej, for this wonderful talk and raising this problem that we probably do not anticipate it, that immunodeficient patients can present this chronic secretion and make the work more difficult to eradicate this terrific virus. So I don't know if there are some questions in the Q&A or in the chat. If not, maybe can I start with the first question? So do you have any data on immunocompromised patients treated by immunoglobulin substitution, how they are protected or not from this specific virus?
Okay, I was trying to unmute myself. So we do very often IVIG, either IVIG or IG subcutaneous now, I think, is used as a treatment. And in some instances, it leads to stopping of the excretion, but most of the time it actually doesn't. I think the immunoglobulin, the anti-polio antibodies in a standard IVIG is not strong enough to penetrate the mucosa because the infection is in the guts. And so it seems not to be very active against the infection. That's why we are developing the monoclonal antibodies that we hope would be able to have effect on the infection inside the guts. But the IVIG certainly sometimes helps, but it's certainly not a universal treatment for this.
Mm. So it means as a treatment, but as a for people that are treated by immunoglobulin substitution as the main treatment for B-cell deficient patients, for example, have you some example of people that were correctly treated with this immunoglobulin replacement that presented this infection even with the normal value of immunoglobulin, serum immunoglobulins?
I can have a look into our data set whether that information is there. I think anecdotally, we have heard about cases where this actually provided the treatment, but I'll have to look at what the statistics says in the bigger sample. I don't have that right now.
For example, the Birmingham man, no, sorry, Martin, just the Birmingham man who has an immunodeficient and very long-lasting secretion of the virus, he was treated with immunoglobulins and any other treatment.
Yes, indeed, that one was, and that didn't work. He was treated even with breast milk, as I understand, at some point, and many immunoglobulins and the antiviral as well, and nothing worked. Then COVID came, and he was treated with remdesivir, but we don't know whether there is a causal relationship, whether remdesivir really was what stopped the excretion or it was just a coincidence that he stopped excreting. So we are doing trials with remdesivir.
There is no in vitro data showing that remdesivir could block polio virus development. This is a question in the chat from Peter Cisnar.
There is no, and that's what we are doing at CDC. At CDC Atlanta is doing exactly that, the in vitro testing of whether the neutralization of the virus would happen or not. And I don't have the results yet. But as we've seen so many times, in vitro and in vivo is also very different.
Now, I was very interested in the fact in the child you mentioned from Morocco. So I have two questions with that. So it means that this child has had OPV vaccine, which is contraindicated for a PID patient. So this is the first point. And the second one, does WHO consider doing anything to stop the OPV vaccine, as it is the source problem somehow?
So these are good questions. So the first one, you know, even though it's contraindicated, very often OPV is given as a routine immunization in young age, perhaps before the diagnosis of the PID happens still. Or again, the child might have not received OPV. I'm not sure in this particular case, and been exposed to it because he lives in that country. As I mentioned also, OPV is the only vaccine we have right now that has mucosal activity, that provides mucosal response. And the mucosal response is what we need to interrupt transmission. IPV is great, and it works in Europe and in the US and in developed countries where there is no poliovirus as a protection against paralysis, and it works very well. But we cannot reach eradication without OPV. And there are plans to withdraw OPV, and we are working on those, but we first have to achieve eradication. So once we do that, then we withdraw OPV. So most countries in Africa, for example, still use OPV, many countries in Asia, some countries in South America, but in Europe, I think almost nobody.
And Ondrej, I was thinking, so it's still very rare. So we can't go with a systematic screening of all the immunocompromised patients. That would represent a big effort to screen all the patients. So what is your message? In which situation we should be particularly cautious to screen this patient, to think about poliovirus, and in European area especially?
So this is what we are struggling with ourselves as well. How to have the net wide enough not to miss the patients, but at the same time be feasible and have a system that's doable. So I think for European region, I think what we would be very happy with is, of course, if a PID patient becomes paralyzed, then that's clear that a stool should be tested for presence of poliovirus. I would also perhaps add to that, you know, again, patients coming from countries where OPV is used, or patients that you know that traveled to countries where OPV is used, perhaps think about sampling think about sampling stool for poliovirus. That would be perhaps my suggestion to the countries that do not use OPV in routine immunization. The countries that do use OPV in routine immunization, I think it would not be impossible to think about sampling all patients with PIDs of importance. And there shouldn't be that many children, right? I mean, the SCIDs and the common variable immunodeficiencies, there are quite a few in each country, I would think. And so, you know, the ask there is to raise awareness and think about it in these situations, I would say. And if you are interested, you know, have a look at those guidelines that are on the website, what is being asked for. It's very simple, basically. Just, you know, sample for poliovirus if you have any doubt.
And I think, so if there is some flyer, I suspect that for advices that we deliberate to primary immunodeficient patients when they are traveling, that could be something, an additional line to mention these specific things. When you travel in a region where you can find this vaccine-derived virus, maybe be cautious if these symptoms appear, and it still can exist, and it still can be imported after your travel in Europe. So we could refer to, of course, this broadcast that will be available on the RITA network, but still we can also mention this to our colleagues that are in charge with the traveling people information, and to mention this specific issue. That I see so maybe if there is some flyer or additional material, we are very happy to disseminate this information in all the network. And I see Peter's is now additional question, as you mentioned the importance of mucosal immunity. Are there any data on IgA deficient patient and chronic polio for those that have a specific deficiency in immunoglobulin A deficiency?
Yeah, I think on the table, if I'm not mistaken, we had the isolated IgA deficiencies. They certainly are part of the picture. So that's a PID of interest for us, I would say, even the
mostly asymptomatic, so this is a big deal somehow. I have a question regarding awareness. As I represent patients, how do you think about, how would you see a patient awareness on that? Because you mentioned coming from an OPV country or traveling there or having family there. So should we have some kind of action to the patient themselves or the patient organizations as we have our members? How do you see that?
I would say the awareness is probably what would be welcome to present. I mean, I would definitely not discourage the travel or some kind of a travel warning. I think that's not necessary. I think what would probably be advisable is, you know, do us at some point after the return from the country, or if it's a patient seeking healthcare in Europe coming from that country, just do one stool test for polio. But I would definitely not recommend discouraging the travel or warning against it, because the chances are very low.
And we also have the risk of discouraging people to vaccine. This is also something I have in mind, because we fight a lot for the vaccine, and you know about fake news, etc. So
sure, yeah, it's all a balance.
Yeah, true.
So I don't see any additional question in the chat or in the Q&A. I don't know, Martin, if you have already.
It's a bit a side question. Out of curiosity, is there other viruses that are also a concern in addition to polio? I understand that, of course, there is this eradication program, but besides, is there any other?
You mean viruses that are a concern for PID, or that are?
Regarding the factor and the fact that they can lead to epidemic.
I'm not sure. I would have to look around. I'm not sure I worked specifically for polio, so I'm not sure, but I'm sure.
Because at the time we told that about the SARS-CoV-2, where a PID patient could be recipients as well. And yeah.
Yeah, I think you are more expert on that than me.
So, sorry about that. It was a side question.
So yeah, I think, Andre, we come to the end of the discussion and presentation. So again, one thanks for giving this talk, and we are very happy to disseminate this important word to all the ACID community in particular, but maybe not only primary immunodeficient patients, because I suspect that all the patients and the treatment that have low IgG may be also concerned by this chronic infection and secretion. So, so thank you again. It will be broadcast, made available on the website. Thanks, Denek, for the technical support. I thank Martin for attending and sharing with me the session. I know it was a challenge because Martin was flying with the delay, and that's fantastic that you can make it, and all the audience for coming there. And we will give you all the program of this webinar very soon. We are still working on this, Thank you, and see you at a Tuesday lunch with Rita some days. Bye-bye.
Thank you, Alexandre, for your hard work. Bye-bye.